Hi, everyone. Arti Masturzo here, back with Living Connected. I'm so excited to introduce our guest today. A really cool guy, but above that, not just being such a cool guy, but also the president and co-founder and chief medical officer of Thyme Care, Dr. Bobby Green. Hey, Bobby.
Hey, Arti, thanks. It's so nice to see you again.
It's so great to see you. Okay, so we're going to dive right into this, but before, because I have so many questions and we don't have that much time. So let's perhaps, because I'm sure the audience doesn't, know a lot about oncology, at least not as much as you do, and your experience with Thyme Care. Can you just give the audience a brief overview of Thyme Care and what you do?
Sure. As you know, I'm a medical oncologist by background, and I practiced in a community oncology setting for a number of years, and got to Thyme Care via Flatiron Health, which is where I was immediately before this. The sort of high level way to think about Thyme Care is we partner with any risk-bearing entity. So think about health insurance plans, risk-bearing primary care groups, oncology practices that are taking risk. And we go to them with a proposition that we want to help them deliver higher value care for their cancer population and lower the total cost of care while improving the patient experience. And we effectively deploy two things to do that. The first is our virtual cancer navigation platform, which addresses everything from disparities in care through electronic patient reported outcomes to symptom management to education to a lot of issues around end of life care, goals, values, preferences, making sure people get appropriate palliative care. So a virtual navigation service that we deploy across all the actively treated cancer patients in any partnership that we have. And the second thing that we do is in every geographic region where we're partnering with a risk-bearing entity, we partner with oncology practices as well. And we effectively build shared savings arrangements with those oncology practices to quite honestly help sort of put them into the value-based arrangement and set up the right incentives to help them drive higher value care, inclusive of all of the things our navigation platform does, keeping people out of the ED, keeping people out of the hospital, better end-of-life care, but also encouraging high-value therapeutic or drug decisions to try to bend the cost curve on drugs as well.
So it's funny you brought up the end of life care. So last week I was seeing patients, and as you know, I'm in the advanced wound care space. So I see especially those that are coming out of the hospital with stage 4 pressure ulcers, advanced dementia, etc. And it's shocking to me, Bobby, how uncomfortable clinicians are about end of life conversations. I've never. It's shocking. I see it all the time. I don't know. What do you think? You probably see it all the time as well.
Yeah, I think there's a lot of reasons for it, and it's across the spectrum. I think there are some circumstances where people just don't feel comfortable, maybe because they weren't trained appropriately, they don't have the right tools. As one of my colleagues here at Thyme Care, Dr. Julia Friedman, who's a palliative care doctor who works with us, consistently reminds me a lot of being able to effectively have these conversations is about having the right tools. Some of it, quite honestly, has to do with when people trained. I would say, this is anecdotal, but in my experience, more newly trained physicians have had more exposure to training and education around this as part of their training. Part of it is the difficulty. Just it's a busy day. You're juggling a million things, especially in oncology, and trying to do that. And I think sometimes, there's this phenomenon, and we've certainly observed this at Thyme Care, where patients don't want to tell certain things to their oncologist because, they don't want to disappoint them. And, when sitting on as the oncologist, we want to hear that information, but sometimes for understandable reasons, patients may not want to share that with us.
Yeah. And that problem is not unique in oncology, right? The amount of time that it takes to deliver good care. And I think that's probably the challenge in almost every transaction that occurs in healthcare today. Whether you're in my world and you're in the supply medical delivery in the home or oncology or wound care or kidney care, it just seems like we just don't have that. We don't have that precious thing, the most precious thing, the time to actually deliver the care that we want.
100%. And I think, in a fee-for-service environment, which is what most care still is delivered in the United States, there's not adequate reimbursement for the time that people need to spend to have these conversations, and it's clearly a problem. And I think it's part of why what I really love about what we're doing is we are in these value-based arrangements and creating these value-based arrangements that really incentivize and to be honest, create the financial model where it makes sense to spend the time doing that. But it's a great point.
Yeah. Okay. So I was having lunch a couple of weeks ago with some friends, and I said something, and they both they're not clinicians, but they looked at me and they said, "Really? Are you sure?" And I don't know why I came up with the comment, but I said that I'm convinced that in the future, the most expensive and prevalent chronic condition, not prevalent, but the most expensive chronic condition is going to be cancer. And am I crazy for saying that? Because here's how I think about it is you've got, 2 million people getting diagnosed annually, but a significant lower number of cancer deaths, people living with these cancers, new drugs coming out, and folks are living longer with, I'm sure, all the other complications that coming. I don't know. What do you think?
Yeah, you're definitely not crazy. I think I don't have I can't cite you the numbers that support it off the top of my head, but you're 100% right. I mean, while in so many diseases, we still have a long time to go, or a long ways to go. There are certainly so many cancers, now that are really managed as chronic diseases where people can live for many years, in some cases have a normal life expectancy, but there are still toxicities related to either the cancer or the treatments that they're getting that need to be managed. And that number is, for very good reasons, only going to continue to grow.
Yeah. And from a cost perspective, I was visiting a family member a few weeks ago, and we were joking because he has a 90-inch TV in the house, and it's huge. And it's my uncle. I said, a 90-inch TV? Are you kidding? Why do you need a TV this large? He said, Arti, but they're so cheap now. And it made me realize how it's in healthcare, you come out with new technologies and new drugs, but healthcare never gets cheaper. It just gets more expensive. Whereas, the first TV, do you remember when the first LED TV came out? It was thousands of dollars. Now you can go to Costco and get one for a few $100. And it's just the total opposite. And so to your point, you've got folks now living with cancer as a chronic disease, new medications coming out to treat the symptoms or the toxicities of the drugs that you're taking to live longer, and nothing's getting cheaper. And I don't know, I struggle with how we control costs in that environment.
Yeah, it's a great question. I don't think that there is a magic bullet. To your point, along with a lot of the great advancements in cancer care, there has really been an increase in cost, and I think there are multiple things that are playing a role in that. I also think the way when we think about cost, part of the question is cost to whom? And I think what you're sort of referencing in a lot of ways is the cost to society. We have a rise in healthcare costs that, for a lot of reasons is probably not sustainable. And equally important is the cost to the patient. How much is a patient paying out of pocket? And we know that medical costs are, especially around cancer, are a big form or a big cause of bankruptcy and the term financial toxicity, which appropriately I think has gotten a lot of play recently. The approach that we are trying to take on the drug side is, we in a fee-for-service environment, we actively disincentivize when there are high-value drug decisions, when there is a less expensive therapeutic compared to a more expensive therapeutic. We actively disincentivize this, and one of the things that we're trying to do across a variety of space, parts of the oncology drug ecosystem is really flip that incentive model to create incentives for delivering that higher value care where it's appropriate and the right thing to do for the patient.
Yeah. It's compensation will always drive behavior.
100%. And, you can't expect physicians or any profession not to, as long as you're treating the patient appropriately, not in a way that is, going to be the most sustainable for your practice. And the problem is that there just aren't enough value-based arrangements right now for people to, that actually drive those right incentives. And that's a big part of what we're trying to do.
Yeah. So for listeners who may not understand the nuance of value-based care, and I have to tell you, in my time spent at a large payer, folks define value-based care very differently, and it's used very loosely. How does Thyme Care define value-based care?
Yeah. So, one of my sort of rules that we always had when I was in practice, and that has really carried through to Thyme Care, is there are plenty of ways that you can, build a business, do the right thing for patients if you start with a focus on what's right for the patient. And so I think, if you sort of think about the value of the value equation, which is quality over cost, it's really starting with the numerator of that, and what things can we do to improve quality, to improve the patient experience, and what are specifically the things we do that increase quality, that are also going to decrease the cost in the denominator of that equation. And I think sort of the perfect example, if you go back to the navigation work that we're doing and the end of life work that we're doing, if you prevent people from being admitted to the hospital unnecessarily, that is a good thing for the patient. It is a good thing for the patient's quality of life, and it is less expensive. If you make sure that a patient gets care at the end of life that is aligned with their goals, values, and preferences, that is a good thing for the patient. It's something that improves quality of life, and most of the time, that's going to also reduce the cost of care. But I think, the framework that we generally take when we think about value is starting with the patient, and letting that sort of drive areas where we're also lowering the cost and increasing value.
Yeah, I love that approach because I part of the challenge with the way that the value-based care world, and even just in terms of health plan performance, as you know, gaps in care and HEDIS measures and star quality measures, is those things become a check the box exercise, and you
Yes.
lose the whole spirit of why you're doing the work in the first place. And what I like about the approach, and it's similar to what we're doing in my organization, frankly, is if you set out with the goal, we're going to reduce total cost of care, we're going to improve the patient experience, right? We're going to defragment healthcare. We're going to improve quality outcomes, and you work backwards from that. Then you know what to do to achieve the goal, as opposed to, I think, the way it works in many organizations that have a different approach to yours is you do this check the box exercise, and then you end up in the end and you may not even move any of those needles.
Yeah. No, 100%. And I think, it's interesting you say the check the box thing really resonates. One area that we think about that a lot and this is something we hear from oncology practices all the time, there's been a big push to ask patients about social determinants of health and barriers to access. And one of the things that, you consistently hear from docs on the front lines who are taking care of patients is, I don't like being forced to ask questions when I don't have the tools to actually address the answers that I'm getting. So, one of the things that, we have really focused on in that space is, if we're going to ask someone a question about whether they don't have transportation or whether they have food insecurity, like, I don't want to ask that question if there's nothing I can do about it. And so really being able to build not just the ability to ask those questions and to do those things at scale across a large population, but how to find solutions to those things at scale. So to your point, you don't ultimately just become a check the box.
Yeah, absolutely. So how do you define success? Like, what do you measure at Thyme Care that says, hey, we're hitting on all our targets?
Yeah, so we have, like all companies, we have a variety of KPIs, and I think one of the ways that we look at this, and I'll just sort of again go back to the navigation work we're doing, and we look at what is the rate of people who are being admitted to the hospital? We break that down by preventable and non-preventable admissions. We look at what is the rate of people who are getting palliative care consults when it's appropriate. What is the rate of people getting hospice when appropriate at the end of life? How often is chemotherapy being given in the last 14 days of life? So all, metrics that are important or impactful. But then below that, a lot of time measuring, what we would call the operational metrics that lead up to that. So we deploy electronic patient reported outcomes, which is a proven tool for keeping people out of the hospital and tracking what percent of people who should be getting these electronic patient reported outcomes are getting them, what percentage of people are answering them, what percent of people with advanced cancers are getting appropriate goals, values, and preferences conversation. And so really sort of building out a measurement model that, not only allows us to measure ultimately those things that are important, but also the things sort of lower down operationally that we believe are gonna drive that value. And then I think, on top of that, it's always important understanding the patient perspective. So really measuring patient satisfaction is another important thing. Starting to measure caregiver satisfaction, which I think is something that's really critically important in this space as well, and that often gets overlooked.
Yeah. Yeah. Is there something that stands in the way, if you had to list the top challenges that keep you from being successful, that makes this really hard?
Yeah, I think for any company that is in the space we are, which we would consider ourselves a value-based care enabler. And what that ultimately means is that we are reaching out and trying to engage patients and trying to help patients where we are not the medical office that's taking care of them. So we might be reaching out to a patient on behalf of their health plan. We might be reaching out to a patient on behalf of their primary care doctor, on behalf of their oncologist. And I mean, I don't know about you, but I get at least 10 spam phone calls a day on my phone and at least 20 texts like asking me to do a variety of things. I think our patients are the same way. And so how do you, in a remote environment, in an environment where, the patient may not have even heard about you, how do you build that trust, engage patients, through a variety of tools? What's the right way to engage people when they answer the phone? How do you work with your partner to get the right marketing materials out there to explain what you do? I think that, that's something that we have gotten a lot better at. That I think is sort of in general for any company that's in the space that we are in, that is a big challenge. I think, to your point, being able to measure the outcomes and be able to track them and to be able to iterate in real time and make sure that you're sort of, making the adjustments to your model that you need to make, I think is something that's hard, but, to date we've been pretty successful with as well. But I think, building the trust and engaging patients, and that's, because everything flows downstream from that, right? If you can't build that relationship with the patient, like, everything that we're doing is to a very large degree based, built on the trust.
Yeah. No, I love that you said that. It's actually the main reason why I'm at the organization that I'm at. And the whole reason I came to CCS was because I agree with you. You can develop any clinical program, intervention, fancy stuff you want, but unless you have trust and engagement, nothing's happening. Nothing's changing. And it's the hardest. You can't buy it, right?
Yeah, you can't buy it. I will tell you, just because this just recently happened to me, a fun anecdote. As as a physician, one of the joys of being a physician is, like, especially I practice in my hometown, bumping into people who or who you've taken care of. And as I've mostly stopped practicing, that's sort of gone away. But I was recently somewhere nowhere near where I live, where I bumped into someone whose family member was being taken care of by Thyme Care. And that was sort of a really cool experience. And I was, a little nervous asking, but when I looked into it, they actually also really liked Thyme Care too. So that was a good,
that would have been extremely uncomfortable if they had nothing but complaints, right?
Yes, exactly. So
yeah, I doubt it. With you at the helm, I'm sure that folks are getting great care. So.
Thank you, Arti.
Okay, so oncology question. So I started off asking you a question about just the steep rise in cancer cases, especially in young folks, right? In the 30s, folks getting colon cancer. I know personally a neighbor who's just got diagnosed in their 30s. What is the future? It just seems, Bobby, that we're still, for breast cancer, you get ACT. For colon cancer, you get, and all these, you get CHOP for this. It still seems, I don't want to say archaic, but it still seems like we're trying to kill flies with a bazooka. What is the future of cancer care look like? What does it look like a decade from now? Because I'm sure there are people listening to some of these stats going, oh no, well, I eat healthy, but I know this guy and he eats organic and exercise and he still got cancer. And so I'm sure there are folks who worry about their health. Make people feel a little bit better, I guess, is what I'm saying. What do you think it looks like 10 years from now?
Yeah, I just to sort of, in some ways double down on the point you made, like there are some cancers where the way you treat them today, like the way I would treat someone, with metastatic lung cancer today looks very different than it looked 10 or 20 years ago. Probably one of the biggest examples is metastatic melanoma, which has multiple treatments now and used to have none. And then there's some cancers where you're, to your point, like CHOP, for non-Hodgkin, lots of non-Hodgkin's lymphomas, is there's been some modifications, but in some ways it's very similar. I think what I would say is that it is sometimes easy it's sometimes easy to not appreciate some of the progress that we have really made in a lot of diseases, because in some other diseases we've really just lagged behind. I think that the technology and the learnings that we've had from a variety of diseases is going to sort of ultimately translate into areas where we've had a harder time. One area, just as an example, is, in some diseases, CAR T therapies, adoptive T cell therapies have been, just incredibly transformative and life-changing. It's early in thinking about how those are going to get applied to solid tumors, but there's a world in which those really become incredibly impactful in solid tumors. And it's still almost every day that I will run in or interact with people who will be treated with therapies that weren't available a year or 2 years ago.
Yeah.
I think the progress doesn't happen overnight. It happens sometimes very incrementally, but it is happening, and it does continue to accelerate. I think that the world, just like we look back 10 years from now and think, wow, how much different it is today. I think it's going to look a lot different in 10 years. I don't think in 10 years we're going to be, we're done, but I think the world's going to, it's going to look a lot different. And we'll be in a situation where a lot of diseases that we're not tackling well enough today, we are down the road.
I think the vaccines are pretty fascinating. What are your thoughts? I'm sure you're following all that stuff pretty closely.
Yeah.
What are you, skeptical? What do you think? Promising?
I would say cautiously optimistic. How's that for that for a hedge?
Yeah.
So, I think the other thing is on the sort of early cancer detection, as there are, multiple companies that are out there in the space sort of thinking about that. And I think, we are still early, but I do believe we will get to a point where we are able to meaningfully address cancers at an early stage, where it is important to find them at an early stage. And I make that distinction intentionally because, as there are, some forms of prostate cancer that we would be better off not knowing about, as an example. So I think there's a lot of nuance to developing good screening tests, but I think that that's something that we are going to see, a real change over the next 5 to 10 years as well.
Yeah. Okay. I have one last question for you.
Go.
So the reason this podcast is called Living Connected is I personally feel like in healthcare, there's so much conversation about this, so nothing new, but the connection is everything in healthcare, and it's what ties us together as humans. So how do you think about, as you think about connections in your life, is there a connection professionally or personally that has been particularly meaningful through your lifetime, your development? It could be personal or professional.
I'm gonna put out a professional one,
Okay.
or maybe a professional theme. Um, I am continually struck, and then I'll give you the anecdote. I'm struck by the how lucky I've been to be able to maintain relationships that go all the way back to when I was in medical school, and when I was in training, and that has really spanned collaborating with patients over the years, as well as developing friendships, and really having good mentorship along the way. So what made me think about this is at the ASCO Annual Society of Clinical Oncology meetings back in June, the ASCO president the prior year was an oncologist named Lynn Schuchter,
Hmm.
who was one of my mentors at Penn. And, for your listeners who aren't oncologists and don't go to ASCO, like being the president of ASCO is a big deal, and
Yeah.
you go and give the presidential address in front of tens of thousands of people, and I'm always the guy.
International attendance.
International,
It's
like
a
from
big
all over
deal.
the, yeah.
Yeah.
And it's only in Chicago because apparently that's the only city that can hold this meeting anymore, at the McCormick Center. And I'm usually, in the back of the room at these sessions because I'm in the back of the room. But this year, I was up at the front of the room with with other fellows that I trained with, and it was a little mini reunion up there as Lynn Schuchter was getting ready to go up and speak, and afterwards. And I was just sort of there with all of these people that I trained with, and I practiced in South Florida, and I had lots of patients who went back and forth to Philadelphia and West Palm Beach, and so I'd sort of collaborated with them on patients, and I just felt so fortunate to be a part of that community and to have developed these friendships and these mentors that this is now, God, it's depressing to think about 30 years later.
Wow.
I'm still have these relationships and still talking to these people, and, also the ability to be sort of quite proud of my mentor as she was up there as well. So, yeah,
I love
that's what
that.
comes to mind.
And
So,
I'm sure, Bobby, that there are people that you mentored that where they asked they would probably say Bobby Green. So
well,
it's sort of, it just goes circular, right? It's paying it forward.
thank you. I like to think that.
Yeah.
Thank you. Yeah, it's funny. The other thing I'll say in medicine is that there was one of my former attendings there, and I mentioned this to him that was there. He said things when he just had a certain way of saying certain things when he walked into an exam room, and so like this is in 1996, and I still speak that way when I go into patient rooms today because like I learned that
Yeah.
3 decades, and it's like just interesting how those things sort of
Yeah.
carry on. So.
Yeah. Awesome. All right. Well, thank you. Thank you. Thank you. This is one of the best conversations I've had in a really
Uh,
long time. Thanks, Bobby.
well, Arti, thanks. This has been fantastic. I appreciate
Great.
you.
Bye. Take care.
Bye.